Yeah, no pressure at all. Okay, so questions, comments, concerns that I can help with. Yes, that's gonna get posted today. I got your badge pictures sent off this morning. So yeah, that was my project this morning. I'll get your homework stuff posted today. And yeah. Any questions on Zoom? Everybody good?
Just out of curiosity, does the homework need to be, do you want it handwritten?
I do. You know me well. Homework has to be handwritten, not typed. Such an archaic thing to ask you guys to handwrite stuff. It's crazy. In cursive, I should put that in. All right. So. They don't teach it anymore. Oh, I did too. The dotted. Yep. All right, guys. So neurologic. What are we dealing with today? The brain. So yeah, we're going to talk about stroke. We're going to talk about seizures. Those are probably going to be the biggest heavy hitters today. There's a lot of different kinds of seizures. There's different kinds of stroke. But anytime we have a neurological emergency, something in the brain is not working appropriately. All right, so we're going to go back over some A&P. We're going to do a quick review of the brain, what it does, how it's important, what it needs to function. All right, so remember this little diagram. What is the cerebrum, this big portion of the brain? What is that responsible for?
Well, no, it's the left and right portion, so like your creativeness.
So we have like a left and a right hemisphere, right? If you say somebody is left-brained, their left brain is more active. What kind of traits might they have? So they're more logical, right? So left L, logic L. They like analytical stuff. They like rules. They like numbers. All of that jazz. The right side is going to be the creative. They probably thrive at maybe music or creative arts, painting, writing, any of that fun stuff. Okay. The cerebellum, what's that responsible for? Gotta have bio people in here.
Just like systems that you don't like consciously think about.
So that's gonna be the brain stem, right? Because this little guy right here controls all of our vital functions. We got a lot of fine motor coordination, balance, all of that stuff, sight, and that little cerebellum. How does all of this connect to the spinal cord, which is the kind of the pathway for all of these messages to be sent to the body? So yes, but like how does it physically go from the brain and through the spinal cord? What's that opening in the skull called? The foramen magnum. Yeah, so again, guys, fine motor coordination, balance, all of that stuff is the cerebellum, this little pizza pie looking thing back here. Oops. And then obviously vital functions, blood pressure, vital sign regulation, all of that stuff is controlled by the brainstem. So again, we are going to talk about the different lobes of the cerebrum because remember they correspond with different parts of the skull, right? We have a frontal lobe and we also have a frontal aspect of our skull, right? We have our temporal plate or bone of the skull. We have the parietal and the occipital, that bringing back stuff. Okay. All right. So the frontal lobe, what is the big factor that the frontal lobe controls? Oh, absolutely. So yeah, daily activity. All right, a lot of that is emotion and thoughts. This is where your filter, if you will, is, because there's that saying, you should think before you speak or think before you act. Some people are a lot better at that than other people. But guys, this is where, especially in like a traumatic brain injury, if the frontal lobe is affected, you will see people come out of this injury with just completely different personalities. All right. We talked about how Alzheimer's can kind of change the personality of somebody because the makeup of the brain is affected, but especially this frontal lobe, if it's a frontal lobe injury, most of the times you'll see these patients they act completely opposite of how they were before the injury, because that filter of what they're thinking and how they act on that thought is vastly skewed. Okay. So parietal, we've got sensation, movement, sometimes on the side here as well, and temporal, and then the occipital lobe, sight, smells, all that fun stuff. Okay. So how does the brain work? What does it do? How does it tell my legs right now to walk around and take steps while I'm moving and talking? Like how does this all work? How does it come together? So it sends signals to the nerves of that particular part of my body, right? And then tells that sensory, or not, sorry, the muscular aspect to contract and to move and to do things I physically want to do, okay? We have to have that open highway, right? All of my exit ramps have to be open through the vertebra for that spinal cord, for all of these nerve endings to go out to the corresponding parts of my body, to have those messages from the brain to those muscles and those nerves relayed. Okay, so everyone's clear that if we have a spinal cord injury or any type of degradation to the spinal cord, those messages don't have an open pathway. The brain could be working totally fine and be saying, hey, left leg, I need you to move. I'm telling you to move. Why aren't you moving? But that left leg's not hearing anything the brain's saying because that exit ramp is shut off through that spinal cord injury or injury. Yeah. Everybody go with that? Okay. There's a picture of what we were just talking about. All right, so everybody with me so far? Yes. All right. So again, guys, the brain is super, super sensitive. It's very sensitive on its oxygen levels. It's very sensitive, like we talked about yesterday, for the glucose levels. It's also sensitive to pH levels. If there is any significant change in any of those levels that are not at that homeostasis level, the brain starts to kind of have glitches, if you will. Because guys, what's the brain to our body? It's the computer brain. It's the motherboard, right? Literally everything we do, everything we think, say, our heart rate, our respiratory rate, our movement of our body, everything is controlled by the brain. If our brain is not sending out signals and telling my body what to do, my body doesn't respond. All right. So if we're starting to have glitches in the brain because we're seeing dips in O2 levels or glucose levels or temperature levels or pH, we start to have global problems because we absolutely need our brains to live. Okay, headaches. This is technically a neurological complaint. Most of the time, guys, headaches are not going to be a neurological emergency. But you will be surprised at how many people will call 911 to get an ambulance to their, residence or wherever they are because their head is hurting. Because there's several different kinds of headaches, different types we talk about. Some of you guys might be able to relate to. Most of the time, these are not cause for concern. I don't want you guys to get that tunnel vision to think that, oh, it's just a headache, they're fine, there's nothing wrong with them. Because a headache can be an indication of something bad. All right, it can be a a symptom of a hemorrhagic stroke. It could be the symptom of possibly something structural, like a brain tumor or some fluid on the brain. Okay, so don't get that tunnel vision. We will have different signs and symptoms going along with that headache that might raise up those red flags But for right now, we're going to talk about just kind of the non-emergent types of headaches you're going to get. All right, tension headaches. What is this? What is this caused from? Stress. All right, if you guys ever notice on a daily basis, especially when you get stressed, you might not even realize it, but your muscles are tensed up in certain parts of your body. All right, so especially when you're super stressed, like with me, I've noticed it throughout the years. I will have to like relax my shoulders and my neck because that's where I hold my stress. All right, so the tension of those muscles, especially if it's in your neck area or the kind of the inferior part of your body, can cause a headache. It can, to a certain extent, compromise the vascular supply to your brain, and just that constant tension can cause a headache. Typically, if we have a patient who has a headache, we do want to give a little bit of, hey man, what you got going in your life right now? Is there anything that's, are there any big stressors in your life? That might be part of that sample history or that interview process with your patient, because if they're like, oh, well, going through a divorce, my dog just died, I lost all the money, my wife's trying to take the kids. Okay, yeah, I can see why you have a headache. All right, so a lot of times these tension headaches are secondary to stress. So kind of open up that door and see if that's a possibility for what's going on in the patient's life. All right. Not going to be life-threatening typically. It's going to be like a squeezing or a dull type pain. Has anybody ever had a tension headache?
Yeah.
Anybody ever been that stressed out? Yeah. Okay. So yeah, it's not like an excruciating pain. It's just annoying. So typically we don't see an immense pain level with a tension headache. We'll see that corresponding to higher stress levels or big stressors in the patient's life. We typically are not very concerned if we can kind of have this background to say, oh, it sounds like a tension headache. Sounds like you're stressed. Sounds like you got a lot going on. Guys, obviously we're still going to take vital signs. We're going to make sure all of those are fine and stable, but this is a possibility of a category of headache you might run into. Migraines. Anyone here ever had a migraine? All right, guys, I had chronic migraines. I was on medication for them. I was doing all sorts of things for them. They're awful. All right, they still don't 110% know exactly what causes migraines. They think it's temporary vasospasms to the vasculature to your brain, so that temporary lack of the blood flow they're thinking is what causes migraines. If you have ever had a migraine, you know that they are typically going to be isolated to one area of your head. Like every single time I get a migraine, it is right here. I can feel it start to throb right here, and I'm like, oh crap, I gotta overload on Excedrin, go drink a ton of water, and try to ward it off. So typically it's gonna be isolated to one area of the head. Guys, these patients are going to be there's a lot of cardinal signs and symptoms that come along with a migraine that we can differentiate it from just a normal headache. All right, what are some of those? Nausea, vomiting. Guys, I get the full gamut. When I get if I get a migraine, if I can't get rid of it in time, nausea, vomiting is definitely sign symptom. Photosensitivity is a massive one. What does that mean? Yeah, guys, if there are any sources of light around this patient and their eyes are open, that light intensifies that pain of that migraine. Maybe.
Do you ever see like auras or
I do.
stars and stuff like that? I
get visual disturbances. That's another one. I start to lose my peripheral vision. So at first, when I first got my full-blown migraine, I thought that like my sugar was dropping or I was about to pass out, because if anybody's ever passed out before, you guys know it kind of gets like that tunnel vision until you just like go completely black. I'm like, what is happening?
Anxiety.
Yeah. So visual disturbances, you can see kind of like specks or like the floaters, if you will. What else? This is kind of the same with all of the headaches, but it's especially a trigger for migraines. Noise, sound, right? When I get a migraine, guys, I have to be in a pitch black, cold, silent room for about 24 hours. They will knock you on your butt, especially if you take medication to ease the pain from the migraines. If I take that in congruence with having a migraine, I'm incapacitated for 48 hours. So you will know if your patient's like saying, oh, I'm having a migraine, but they're sitting there scrolling on their phone, posting about their headache, or, you know, listening to music or talking on the phone. Pain is subjective, right? But if I cannot be anywhere near light or noise when I have a migraine, or it feels like somebody literally just has a hammer just banging into my brain.
In most cases, is totally incapacitating.
Hmm?
I thought it was totally incapacitating. I haven't had
It typically is. Yes, but it's just like I have, you know, I guess acquaintances who will post like hourly on Facebook. Man, this migraine's crazy. This is the worst migraine I've ever had. And I'm like,
They don't have a migraine.
there's no way you have a migraine if you're posting on Facebook on the hour every hour. And that's just me. But
My mom has like stage 4 brain cancer, and her migraines get so bad she has to have a shot, and it just puts her down for the count.
that's what I used to have. Imitrex shots.
It looks like a
Yeah. So migraines are a different beast. Usually isolated, photosensitivity. You can get nausea, vomiting, visual disturbances, all that jazz. Guys, how are you going to treat a tension headache? What are you going to do? I mean, that doesn't go over well with most people.
Advil and water.
Huh?
Advil and water.
I mean, we can't give that, right?
Yeah.
That's not within your scope.
Do ice or heat pack.
So, I mean, yeah, if they want a cold pack to maybe alleviate some of the pain, a heat pack, whatever works for them. But just have maybe an educational moment too, because if these patients are thinking they're like dying because they have this headache, well, actually, this is probably attributed to the stress you have in your life. You know, try to see if your muscles are tensed right now. Like, you know, just like educate them as to this is why you're having the headache. And maybe I'm not going to tell them, hey, man, just take the stressors out of your life.
Mm-hmm.
Much easier said than done. But just let them know, you know, this can happen if you're under a lot of stress. So just kind of like listen to your body type thing. How are we going to treat a migraine? Yeah, guys, just be sensitive to your patient. Turn the lights in the back of the truck off. Maybe turn the volume on your radio down and just talk to them as little as possible. Right? Hey, man, I know you're hurting, but let me get these set of vital signs. Let me ask you these few questions, and then I'll just leave you there in silence. Right? Just understand that, guys, if you have not had a migraine, you don't understand the pain that comes with a migraine. It's awful, awful, awful. It is pulsating too. Like I can sit there if I'm just laying in bed, like I can feel my pulse through the pain waves in my head. It's weird. So yeah. Sinus headaches. What are these? How will these present?
This usually occur during inflammation.
Right here. Right, we're behind or right in front of where your sinus cavities are. This is typically going to present usually during the spring or the fall when there's different things blooming. There's an increased counts of pollen. If people are sensitive to the pollen and have seasonal allergies, all right, this is typically going to be corresponding with that type of ailment caused by the irritation, the accumulation of that fluid and that mucus and all that fun stuff in the sinus cavities. It puts pressure and causes a sinus headache, which usually is about right here in the spot. Because all of that mucus is produced, they might have a runny nose. They might have, you know, a little bit of a cough because of that mucus draining from the irritation from the pollen. Again, this is not going to be a major concern for me. Right, especially if it is during the springtime or in the fall, you can ask them, hey, do you have seasonal allergies? Do you normally have to take Claritin or Zyrtec? Or do you know what type of pollen, you know, you're sensitive to? Like my grams, she would be able to tell me if there was ragweed in a 10-mile radius because she was super sensitive to the ragweed. She would get a sinus headache every time we were around ragweed. So if they know, then we can say, okay, these puzzle pieces are lining up. I don't think you're, you know, having a hemorrhagic stroke. Maybe try to take your Claritin like normal. I can take you to the hospital, but there's not a whole lot that we're gonna do for this, right? All right, so again, guys, this small percentage, but this last category we have to talk about, it's not really a particular category, but just so much as understanding that a headache can be a precursor to something bad. It can be an acute sign that something bad is happening. All right, so hemorrhagic stroke is a big one. Okay, we'll talk more about that later on in this chapter, but you can have a sudden worst headache you've ever had in your life, pain associated with a hemorrhagic stroke. Something structural, such as like a tumor, can cause that pressure, can create a headache. Typically, guys, this is something that we get a little concerned with if they have had a headache for weeks or months and then just can't catch a break. That headache's not easing up. There's not a whole lot we can do for this in a pre-hospital setting, right? Because do we have an MRI or a CT scanner in the back of the truck? We're not going to really diagnose, but if we're having a patient who says, yeah, I've had a headache, I've had it for the past couple months, I haven't felt right in the past couple months, I've noticed some other things, then we can be a patient advocate and say, okay, when we get to that hospital, we can probably urge and say, tell the doctor or the nurse, hey, you might want to think about a CT scan. They've had this for a while. They've had some other signs and symptoms just to rule out possibly like a structural tumor or something like that. Meningitis is another one, right? We talked about that yesterday. What are some of the other signs and symptoms for meningitis? Stiff neck, guys. Also photosensitivity is with meningitis as well. But yeah, if they have a fever, if they don't feel well, if they just have that general malaise, right? They're just not feeling up to par, and a headache in congruence with all of that other stuff, we can possibly think meningitis. All right, we'll get to all of this when we talk about strokes. Okay, what part of the brain controls vital functions? Brainstem. What's the structure that the spinal cord comes through? I fed you guys all these answers. All right, the left side of the brain is typically associated with what type of thought expression? Logic. Right side? Those are too easy. All right, everybody with me so far? Okay, everybody good on the different types of headaches? Things that need to raise our red flags versus, hey man, I'm sorry you're hurting, but it's probably just a headache, nothing I can do. Okay, stroke. What is a stroke? Globally, definition-wise, what's happening when we're having a stroke? That's one kind. So there's two different types of stroke, but in both of these different types, what is happening for it to be detrimental to the patient? Lack of blood flow, lack of oxygen. All right, so lack of perfusion for one reason or another to the brain. I think we've already established that, especially the brain, if it's not getting oxygen, that's not a good thing, right? All right, so what is the technical fancy pants term for a stroke? Cerebrovascular accident. I'll never know why they call it an accident, because I don't think anyone has a cerebrovascular incident on purpose, right? But CVA, you will hear that referred to as a stroke as well. That's definitely an abbreviation you need to know. Okay. So like we just said, interruption of the blood flow, subsequently the oxygen delivery, the perfusion to the brain. If the brain's not getting oxygen, it's not going to function.
No.
And guys, just like those cardiac cells, right? If we have a heart attack and those cardiac cells die, they don't come back. All right. For this point in time, where we are with scientific progression, I will say right now, don't you guys? Brain cells don't regenerate. We don't get them back. Okay, so what is that going to mean for a patient if we have significant brain damage or loss of that function of brain? What are some things that can happen? Okay, so we could have just future, maybe depending. So guys, remember going back to the heart attack, the STEMIs, the MIs, right? Depending on what coronary artery gets occluded, depends on what area of the heart is affected by that heart attack, right? It's typically, it can be, but it's not typically the entire heart. It's a section or a portion of the heart that's affected. All right, so it's the same thing here for a stroke. Depending on what section or what lobe of the brain is affected by that ischemia, right, that lack of blood flow or lack of oxygen, depends on how they're going to present afterward, right? Especially if it's lack of blood flow to maybe that frontal lobe. What do you think some changes we might see? Okay, so personality changes, right? If it's to that occipital lobe that controls that fine motor coordination, all that kind of thing, how do you think we might see that present? Yeah, so we might not have that fine motor. We might have, not be able to walk. So it depends on what area of the brain is affected, what side effects, long-term, lasting, lingering, that it's possible we'll see. That makes sense? Okay. So again, guys, there's two types of strokes. We're about to go over both of those. We'll go over the treatments, the recognition, and some really cool things that Grady can do for these strokes. All right. So the first stroke is called an ischemic stroke. The first kind of stroke is ischemic. What's happening here? This is a blockage. This is a clot. Just like in those MIs, those heart attacks we talked about, one of those coronary arteries gets clogged with a blockage, an embolus, maybe that plaque that accumulates, and then that certain part of the heart doesn't get blood flow. Same exact thing here with the brain. Okay, it can be secondary to that atherosclerosis, that buildup of plaque that just snowballs and gets bigger and bigger and bigger. Or it could be a thromboembolus, right? A clot that forms somewhere else in the body. It broke off and then it gets stuck here in the vasculature to the brain. So either way, we have a clot, we have an occlusion to the vascular components of the brain. Not good, right? All right. Guys, depending on the size of the clot, depending on the area of the brain that it is occluding, that it gets stuck in, you might see mild symptoms or you could see significant signs and symptoms. All right. What are some signs and symptoms of a stroke? Because there's a scale, there's a spectrum, but what are some things you might see if a person's having a stroke? Slurred speech, okay, that's definitely one of them. We're going to talk about a particular scale that you're going to use to test to see if a patient's possibly having a stroke, and slurred speech is on that scale. What else? Okay, so one-sided paralysis or hemiparalysis, typically one side of the body will be affected. You might see those muscles become flaccid. They can't control that one side of their body as well. What else?
If they start speaking and it doesn't make sense.
Okay, so maybe slurred regular speech, or they're speaking, but it sounds like maybe they're speaking in a different language, or they're trying to convey something, but it's coming out as like blue flower pot, purple kitten flower bush. It's not really an appropriate answer to anything, really. What else? Possibly. We might have some unequal pupillary response. Typically not with ischemic stroke. We might see that in the hemorrhagic stroke. We'll talk about that. Anything else? Facial drooping. So again, that hemiparalysis, A big part of that is controlling the facial muscles. And you can see typically one side, like it will look like one side of the mouth is frowning and the other side's not. Okay. Yeah, guys, unsteady gait, loss of that fine motor coordination, the speech impairments are big ones. So again, with the exception of a couple of those, what does that sound like that could be? The signs and symptoms could be something else. Drunk. That's a big one, right? You start slurring your speech. You're not as nimble on your feet. You might have some unsteady gaits. Okay, that fine motor coordination is not there the more drinks you get in. What else? Hypoglycemia, slurred speech, unsteady gaits, maybe starting to get some altered mental status, right, with both hypoglycemia, intoxication, and stroke. Right, so again, guys, this is why medical gets tricky. All of these things resemble other medical emergencies. Every patient, every question, every assessment, every vital, every time, or you're going to miss something, I guarantee it. All right. So especially making sure you're getting sugars. If all of your vital signs are checking out on your patient, your sugar's good, they're adamantly denying, we're not believing that there's any drugs or alcohol involved, then we need to do a differential diagnosis and do a stroke scale to say, okay, it's not this, it's not this, it's not this. Let's see if it's this. Okay. So guys, here's just another recap of the definition of the athero versus arteriosclerosis. It is very possible that arteriosclerosis is also a common cause of strokes, all right? Who do we see this in? Especially the geriatric population, guys. This is a major cause of death, especially in that geriatric population because of that arteriosclerosis. Okay. So guys, just notice here with this picture, this is just a visualization. The vasculature goes to every aspect of the brain, right? So depending on where that clot is or where that obstruction is, it's like a cascading effect. Like it's like a ripple effect. If this clot is here, all of the vasculature from the feet forward has now been stopped. Has now been calmed.
I'm sorry, Professor H. Carl, if you can hear us, can you mute your mic, please?
Can I mute him? Oh yeah, you're muted, Carl. All right. So again, depending on where this clot lands, where it gets stuck, if it got stuck right here, do you think it would have as big of an impact if it was down here? No, because it's just a small aspect of the brain would be included, right? So it just depends where it gets stuck, how much of that ripple effect goes into play to see if it's going to be extremely detrimental to the patient or, recoverable, if you will. Okay. So far, so good? Mm-hmm. All right.
A stroke occurs when the blood flow in part of your brain is blocked. After just a few minutes, the starved brain cells begin to die. Normally, the brain receives blood via two major pairs of arteries, which branch throughout brain tissue and supply your brain cells with a constant flow of oxygen, glucose, and nutrients necessary for their functions. In one type of stroke, ischemic stroke, an artery in your brain narrows or becomes completely blocked, preventing normal blood flow. The blockage may be caused by a blood clot, also called a thrombus, which forms in an unhealthy artery of the brain. The lack of blood flow causes the tissue the artery supplies to become starved or ischemic. Similarly, the blockage may be due to an embolus, a blood clot that forms elsewhere in the body and travels to the brain. The embolus lodges in a narrowed artery and obstructs blood flow. Immediate treatment for your stroke may help to minimize brain cell injury and death. If you have an ischemic stroke, you may be given medication to break up the clot causing your stroke. Later, your doctor may recommend surgery, such as carotid endarterectomy, to reduce your risk of having another ischemic stroke.
Everybody go with that?
Yeah.
Okay. Guys, obviously, when you work for different agencies, you will have a vast understanding of the different hospitals in your area as to what they are, what their capabilities are, okay? In the city of Atlanta, does anybody know what hospitals are stroke centers? Grady, definitely a stroke center.
St. Joseph's, I think.
So I think St. James, because I think the majority of all of the hospitals within Atlanta are technically a stroke center. Okay. You're designated as a stroke center that you have a functioning CT, CAT scan machine, that you have the drugs that are given available on hand and have the equipment to push those drugs, and you have a neurologist either on call or in-house at all times. Okay, so we want to make sure we're taking these patients where? Stroke center, for sure. All right. Now, that stroke center, again, is designated as having the CT scan and a particular drug. Does anybody know what drug? Called what? Yes. It's called TPA. Anybody know what that stands for? Tissue plasmagen activator. All right, so pretty much what that means is that that drug, they'll push that drug into the patient via an IV, and it will target that clot, and it will kind of degrade and break down that clot to hopefully restore normal blood flow. All right, those are bare minimum requirements of a stroke center. Now, Grady and Emory, Maine are the only two comprehensive stroke centers within the city of Atlanta. All right, what can they do differently than everybody else? Everybody else can push that drug, right? Everybody else has a neurosurgeon. If it's the hemorrhagic version, they can take them to OR and they can do surgery. All right, but what can a comprehensive stroke center do that the others can't?
Determine the cause.
Okay, they actually have the equipment, the doctors, the capability to go into the vasculature of the brain with this like little roto-rooter looking thing and physically remove the clot instead of pushing that drug just to break it up. Okay, because guys, that TPA drug, it does wonders. It's great, but it does target that clot in the brain, but it also can wreak havoc on other aspects of your vasculature. Okay, so this is a much more definitive, less risky procedure to remove a clot. Go in, they literally just kind of get that little teeny tiny mesh metal netting around the clot, and they extract it. That's the word. Okay, so if they have the ability to go in and physically remove the clot instead of just pushing that TPA drug, they're considered a comprehensive stroke center. Grady and Emory, Maine University are the only two hospitals in the city of Atlanta that can do this.
Why would they,
No, just good.
why would they remove it as opposed to like in the
balloon. So it's kind of, there's kind of different approaches, but some of the approaches are similar. So sometimes they do put the balloon in to make it wider, so they block the further flow of the clot, but it's the same concept.
So it's pretty risky.
It is. I mean, it's brain surgery, literally. So yes, it is. But it's a little less risky than the TPA because the TPA can also compromise the integrity of other vessels that don't have clots. So you run the risk of maybe causing some bleeding that wasn't there in the first place by pushing the TPA.
Why would it take the TPA down?
So, Professor, I have a quick question.
Yes.
Just so I can make sure I'm understanding TPA is basically the anticoagulant in fluid form is what it is, and that anticoagulant causes the blood vessels to, like, I guess I'm not quite fully understanding what it exactly does to cause a compromise.
So in a sense, it's an anticoagulant. It doesn't prevent the other blood cells from clotting, but it more so, it goes in and targets part of the component of that clot and causes it to break down. So the clot degrades, it gets smaller, and it's no longer obstructing the vessels that it's occluding in the brain.
Oh, okay.
All right, so guys, this is a before and after picture. This is called a thrombectomy, the removal of a thrombus of that clot, right? So this is how, again, guys, you've got to be a stroke center you've got to have a CT scanner, right? Because what does a CT scanner tell us? Because before you get a TPA drug or before you say, hey, we need to take you to surgery, you have to get a CT scan. Why? To know what kind of stroke it is, right? If you get a CT scan and you see that there's a massive accumulation of blood in the brain that shouldn't be there, what kind of stroke do you think that's going to be? Hemorrhagic, right? If you don't see that accumulation of blood, what they do is they'll put you through an MRI machine. All of this black stuff that you're seeing is called contrast dye, and they'll push it through your IV so it will kind of illuminate in this real-time scan to say, hey, I'm a neurosurgeon. I know every single roadmap of the vasculature that is supplied to the brain. I am very aware that whatever part of the brain this is, there should be more vessels up here free-flowing with this contrast dye. There's an obstruction here. None of this is filling up, so the blockage has to be right there. Right? So you can see this is pointing to exactly where the clot is. This entire portion of the brain right here is not getting perfused because that's where the clot is. They determine where the clot is. They go in for the thrombectomy. They remove the clot, and now look at all of that other part of the brain that's getting perfused because that clot's gone. Okay? Yes, ma'am.
The equipment for the thrombectomy, is it like you can move it directionally at the very tip? Because I was just wondering how it got exactly like through.
So they typically will feed through your carotid artery
Uh-huh.
and just literally like roto-root it through the vasculature until they find the clot. Or if it's the vasculature is too small for that, then they'll just kind of open up the skull right there where the clot is. Okay. So guys, it's really important. That's why, I don't know if many of you know, we have a literal stroke truck at Grady. It's a mobile stroke unit, MSU. It is a big, I wish we could have gotten them. We were trying to get them up here today so you guys could see it, but it just wasn't in the cards. It's much larger than a normal ambulance. It is staffed with a paramedic, a registered nurse, and an EMT or a CT tech. I can't remember. But anyway, they've got the appropriate resources on there. They actually have a CT scanner in the back of the truck itself. All right. So it's really cool. There's only a handful of these throughout the country. We're the only one in the Southeast that has it. But how this works is If we get, as a regular 911 unit, we get transported or we get dispatched to a house for a possible stroke, for stroke-like symptoms. We get there, we do our assessment, and we're like, yeah, this patient's probably having a stroke. It takes the time for us to get on scene, package that patient up, transport them to the hospital, call in the report saying, hey, I'm activating a stroke alert. They have to get to the hospital. They have to go to the CT scanner. They have to get their blood drawn. They have to get all the tests done by the doctor in the ER, go to the CT scanner. And then after that CT scan is complete, that's when the course of action starts. They either go for the thrombectomy, they get the TPA, or they go to surgery, right? That's a lot of time. In the grand scheme of things, we try to keep that under an hour. But if your brain's not being perfused, even if it's 45 minutes, which is still technically under that golden hour, that's a long time for your brain not to be perfused, right? So the MSU will co-respond with the 911 trucks if any stroke-like symptoms come out. So 911 truck responds to 120 Main Street, stroke truck responds to 120 Main Street. They'll do their own assessment. If they do believe this patient is possibly having a stroke, they put down these anchor legs of their truck. They do a CT scan right then and there at the patient's house, in the patient's driveway. They have a real FaceTime connection. They send over, you know how you guys can transmit those 12 leads to a doctor at Grady? They can transmit the CT scan to a neurologist at Grady. The neurologist will look at it and be like, yep, it is hemorrhagic. Bring them on in. We'll have an operating room ready to go. Or they'll say, ooh, it's ischemic. Go ahead and do what? Go ahead and push TPA. So they're getting TPA, that clot busting drug, the second, like before they even leave their house. So it is shown, it's been proving to show vastly better outcomes for these patients because they're getting treatment at least an hour sooner than they would had that stroke truck not been up and running. So really cool part of Grady. But yeah, we actually have a mobile stroke truck that can give you TPA in your driveway. Yeah, it's freaking awesome. So everybody clear with what an ischemic stroke is? Yes. Sorry, no, I was thinking. I wasn't waiting on our slides. How they might present, right? And then the end-all be-all treatment for an ischemic stroke, either that TPA drug or that thrombectomy that we talked about.
If you're in a service that doesn't have a stroke truck, is the answer just give them oxygen and transport like
So,
you do for a lot of other things?
At a national level, TPA is within a paramedic scope of practice to push. Now, that being said, that is going to be extremely rural service. If you're an hour or two away from a stroke center, and it's a very risky for that medical director to make that call, yes, push TPA if you think they're having a stroke and you don't think it's hemorrhagic. Because guys, if you push TPA and a patient's having a hemorrhagic stroke, let's think about what TPA does. And what do you think's happening with a hemorrhagic stroke?
They're actively bleeding.
They're actively bleeding. They already have a hole in their vasculature to their brain. If we push a clot busting drug and there's already a hole in an artery, that hole is going to degrade and get bigger, and we're going to kill the patient faster. So yeah, you can technically push TPA in the field if your medical director allows it, but you have to be like 2 hours away from a hospital and just hope that it's ischemic versus hemorrhagic. So. Huh? Not really. No. All right. So guys, ischemic strokes are much more common. All right. Hemorrhagic strokes are less common, but they still account for about 15-ish% of the strokes annually. Okay.
What's the other 5%? Because the slide said ischemics were about 80%.
Oh, really?
Yeah. 8 plus 13 is 90. It's like 95.
I couldn't tell you because I only know of 2 kinds. Maybe a combo? I don't know. There's only hemorrhagic and ischemic, so. All right, so hemorrhagic, guys, obviously if we're hemorrhaging, we've already established what's happening. We're bleeding, guys. This hemorrhagic stroke is secondary to a rupture of the vasculature to the brain. All right. These are going to be more, they're less common, but they're more fatal, just because it's not only dealing with lack of perfusion to the brain, but we're also having what happening internally? Blood loss. All right, we can eventually get to the state of hypoperfusion. And guys, what also is not good about having blood in our skull pushing up against the brain? All right, that thing that we call ICP, intracerebral pressure, or intracranial pressure, excuse me, not good. All right, so on top of not being perfused with that blood, that pressure is accumulating and pushing up against the brain matter, and that's why typically they're less common, but they're more fatal, because there's a lot of more things at play other than lack of perfusion. So people at highest risk are those who have uncontrolled high blood pressure. Why? What did we talk about in the cardiovascular chapter? Can happen if you have extremely high blood pressure. Remember those aneurysms? Your arteries are built to work under pressure. They're a high pressure system, right? Versus veins, they're not really built to work under pressure. But if you consistently got a 180 to 200 systolic pushing up against those arterial walls day in and day out, they're going to wear down. We're going to have that aneurysm. Remember the kind of the bubble in the wall of the artery? We'll have that aneurysm form. And if you're still not controlling your blood pressure, it's eventually going to rupture, right? So uncontrolled high blood pressure is typically the #1 culprit for these hemorrhagic strokes. Does that make sense to everybody?
Are there symptoms with the aneurysm that they might catch it before they blow?
So the only one that it's very subtle, and again, maybe if they've had a headache for an extended period of time, they've tried medications, it doesn't work, they've tried, meditation or like taking out stressors in their life and it doesn't work, that can be a precursor to say, hey, you've had a headache for 6 months, let's get a CT scan done, and then they can find an aneurysm. But typically it's not anything that is very like in your face. Because remember guys, most of these patients who have these aneurysms, whether it's in like their aorta or their brain, they find them by happenstance. It takes a lot for a neurologist to get involved. Say, hey, let's do a CT scan just to make sure you don't have an aneurysm. It's a insurance process and all that stuff. So. Okay. So here again is a good picture of what an aneurysm looks like. Guys, this right here should be the width of this artery. Okay, this is a pretty hefty aneurysm right there. Typically caused from high blood pressure. If we're not controlling it once it's formed, it's inevitable, it's going to rupture. And especially if it's in the brain, not going to be good. The rupture of any artery is not good, right? But it's especially not good. Why didn't you tell me you guys can't see the whole thing? All right, so we talked about before, there are, if they do catch the aneurysms before they rupture, there are different types of kind of procedures they can do to make that aneurysm kind of go out of play so it's no longer compromising the structure of the artery. One of these, it's called aneurysm clipping. So you can see right here is an aneurysm and right here is an aneurysm. If the patient, and right here too. If the patient is stable enough to go in for this type of surgery, they can go in with these little metal clasps and kind of clip off that aneurysm. Okay, that tissue will eventually die, like this little bubble part right here. Or they will have the blood flow occluded right here at the hub of that clip, and they just kind of cut off the rest of the aneurysm. So we're not worried about rupture, and we've restored the integrity to that artery wall. So here's a little whole surgery to watch that. It's pretty cool.
This particular aneurysm is located on a blood vessel called the middle cerebral artery. Aneurysms tend to occur at branching points of the blood vessels. The constant stress of the blood hitting the wall where there's a branch occurring makes that spot particularly vulnerable. In this patient, this complex aneurysm is now exposed within the folds of the brain with very high magnification through a surgical microscope. The aneurysm is freed circumferentially. Once the aneurysm has been completely freed from its surrounding adhesions, it is prepared for clipping. All the vessels are identified so that only the thin-walled aneurysm is clipped, leaving normal blood flow in the remaining blood vessels. This last vessel that's attached to the dome is now being freed with very fine micro scissors. Now the aneurysm is completely free from any attached vessels or brain and is ready for clipping. A clip, which is 7 millimeters, about a little bit less than 1/3 of an inch, is applied across the base of the aneurysm, eliminating the aneurysm from the circulation and therefore from risk of rupture. We inspect around the aneurysm to make sure that flow is maintained. In order to make certain that blood flow is maintained, a test called indocyanine green angiography is performed.
So pretty much they were showing that the glow of the whites in that black and white image was ensuring that all of the blood flow was still contained once that clip was placed. So if they find it by happenstance, they can fix it if they're stable enough for the surgery, but if not, it'll eventually rupture.
Does the clip stay there forever?
All right, so
So when they clip them, are they actually suturing up? They clip it or suturing the side, or does that do that automatically?
I think it does it automatically. They might have some micro sutures in there, but the point of the clip is to totally just like, yeah, it's exactly like what it is. It's target. Because that's why neurosurgeons get paid big bucks. You got to know every single microscopic vasculature to make sure everything's accounted for. You got to have like steady hands. No thanks. Yeah. Yeah, like every time I've ever had surgery, I like to talk to my surgeon and be like, hey, you good? Like, do you need coffee? Do you need like some tea? Like, you need to take a minute, go take a nap before you get going? Because, yeah, you got to have, like, if you go in and your nerves are rattled or something like that, bad day. So have I talked about Berry aneurysms with you guys? I think I've mentioned them, maybe not.
What?
Berry aneurysms. This is not very common, but sometimes if you hear of like a younger patient who had no medical history, all of a sudden just, collapses over and dies, there is a genetic abnormality called a Berry aneurysm where they're predisposed, they have those smaller aneurysms occur in their brain, even though they don't have that high blood pressure. So that would be something that an autopsy would reveal.
That's very like
Berry. Berry aneurysm.
That's from like genetics.
Y'all, I had a student last go around. She was such a hypochondriac. She's like, I didn't know all these things had happened. I need to call my doctor now. I need to go get a CT, make sure it's aneurysms. So yeah, unfortunately, those Berry aneurysms are typically not, unless you have like an established family history of them, they're typically not caught unless by happenstance or until after they rupture.
A stroke occurs when the blood flow in part of your brain is blocked. After just a few minutes, the starved brain cells begin to die.
Sounds very familiar.
Yeah.
Great for their function. During a hemorrhagic stroke, abnormal bleeding disrupts normal blood flow. For example, in an intracerebral hemorrhagic stroke, a blood vessel bursts, spilling blood directly onto your brain, while robbing the intended tissue of nourishment. Both the hemorrhage and lack of blood supply, called ischemia, destroy brain tissue. A subarachnoid hemorrhagic stroke occurs when a weak spot in a blood vessel wall, called an aneurysm, bursts and leaks blood into the tight space between your brain and your skull. The high pressure bleeding results in serious damage to brain tissue. Immediate treatment for your stroke may help to minimize brain cell injury and death in the case of hemorrhagic stroke. Emergency surgery may be necessary to repair damaged arteries or reduce the pressure of the blood on your brain. You may be given medication to help the brain's blood flow return to normal.
All right, so guys, this is a CT scan. So remember I said before we decide 100% confirm if it's ischemic versus hemorrhagic, we've got to have an imagery test done, a diagnostic test done. You can physically see a hemorrhagic stroke in a CT scan. All right, so here, all right, this is normal. We see all of this gray tissue. We see some of these void spaces. That is normal picture of the brain, okay? Because we have some kind of nooks and crannies and some wrinkly aspects to our brain. This, if we see anything like this, that's not supposed to be there. That's either going to be blood or something along the lines of a tumor. All right, so again, that's why a CT scan is imperative. We've got to have that done so we can determine, is this ischemic, is this hemorrhagic, and then subsequently what kind of treatment do we need to give this patient, right? So we've talked about whether it's ischemic, whether it's hemorrhagic, we can have some of the same signs and symptoms, right? That slurred speech, speech impairments, unsteady gait, altered mental status, all that stuff. Those can be present for both ischemic or hemorrhagic. All right, so Ariana said, what about the pupils? Okay, technically, there is more of a distinguishing factor that could possibly be present in a hemorrhagic stroke that's not going to be present in an ischemic stroke. What do you think that is? Huh? Okay, so we have an aspect with the hemorrhagic stroke that's not present with the ischemic stroke, right? And that's that accumulation of that blood. The blood that's coming out of that ruptured artery and accumulating in the skull. All right, so we're going to start to see signs, a particular triad of signs if we have that accumulation of pressure that's causing enough buildup to create that intracranial pressure. No.
Or Beck's triad?
No.
No?
Is it what?
It's
Not Beck's triad. That's for what?
That's a cardiac tamponade.
Cardiac tamponade. There's another triad that you guys need to know.
Cushing's triad.
So this is gonna be Cushing's triad. All right, if we have all of these things present congruently together on top of slurred speech, altered mental status, anything like that, if it's medically based, right? And I have Cushing's triad in place, and I'm going to have a very sneaking suspicion that this is a hemorrhagic stroke. All right, anybody know what my 3 signs are going to be?
High blood pressure.
That's the unofficial 4th sign. It's not technically part of Cushing's triad. Spoiler alert, it's in your book. Or on Google. I'm gonna make you guys work a little bit today.
Hypertension.
Okay, so yes, but more distinctively what about that hypertension?
There's a
Untreated or it stays high all the time.
like greater gap.
Oh, all right. So remember in Beck's triad, part of that triad was a narrowing pulse pressure, right? Because the heart's under that pressure, our systolic's going to go down and our diastolic's going to go up. So with Cushing's triad, yes, it's going to be hypertensive because of the pressure on the brain. But what makes it part of Cushing's triad is a widening pulse pressure. All right, so that means, yes, my diastolic is going up, but my systolic is going way above that diastolic range. So like over a 75 pulse pressure is going to be considered widened. So if you get something like a 200 over 100 diastolic or blood pressure reading, that's considered a widened pulse pressure. Like 100. To have that 100 difference be your pulse pressure, that's considered widened. Technically, anything over 75 for that pulse pressure is going to be considered widened.
Why would a brain bleed cause like significantly heightened pressure to be detectable in like an extremity? I'm not sure I'm following the mechanics behind how that would work.
So we'll get there in just a second because that comes into play with some of the other signs. All right. What's another part of Cushing's triad? Huh? Maybe at some point. But it deals with your respirations. Irregular respirations. Okay. What's the third trifecta?
Bradycardia.
So notice what I've got. What's coming into play here? These are all what? Vital signs. All right, so typically it's going to start having that Cushing triad effect when the pressure is so significant, it's starting to affect the brainstem. So the brainstem just gets kind of thrown out of whack because the brainstem's not used to having any pressure on it. Since the brainstem controls those vital functions, it just gets thrown for a loop.
Is there like a specific irregular respiration?
The most common irregular respiratory pattern you're gonna see is Shane-Stokes. All right, what happens with Shane-Stokes?
Sorry, just looking for my monitor.
Oh, I turned it on. What happens with Shane-Stokes? What are we gonna see?
Comes in waves, like separated by apnea.
Okay, so we're gonna be deep and rapid, and then it's gonna go slow and shallow, and then it's just gonna go completely apneic. And then it's gonna pick back up, deep and rapid, slow and shallow, apneic. So Shane-Stokes is regularly irregular, if you will. Like you can predict what it's gonna do, but it's not normal. Okay. What's my unofficial fourth sign of Cushing's triad? All right. Unequal pupils. If the ICP is bad enough, if I have significant ICP, I might see some differential with my pupillary response. How does that work? Anybody know what's going to happen there? So we start to see some compression for that optic nerve, right? With the ICP, with that blood accumulating. And we will see one pupil will be dilated. It'll be much bigger and it won't really be responsive to light. Okay. The other pupil would be somewhat normal, mostly normal responsive to the light. We'll see that constriction, that dilation.
Would that tell you which side the brain?
Yes. Okay, we have a cross wiring of everything that controls, like, so your right side of your brain controls what side of your body? Left. All right, and vice versa. So yes, it would be able to give you a strong indication as to the majority of the side of the brain that is succumbing to that pressure.
So it's also it's opposite.
Correct.
Professor A,
Yes.
what did you say the third one? The third after irregular respirations?
Bradycardia, decreased rate.
These are symptoms for increased aneurysm pressure. It's constant flow rate.
Correct.
Okay, so they could be another thing, not the same as constant.
Correct. Yes, so guys, that brings up a good point. This Cushing's triad is indicative of intracranial pressure. All right. A hemorrhagic stroke absolutely can cause ICP, but what else can cause ICP?
Tumor trauma.
Possibly a tumor,
Traumatic brain injury.
a brain injury, right? So trauma, I really hope I'm not about to lose my voice. Sorry, guys. Trauma can also cause ICP. So there can be a medical etiology for ICP and a traumatic etiology for ICP. So don't get thrown off that if your patient's presenting with Cushing's triad, oh, it has to be a stroke or it has to be trauma. No, it could be either or. This Cushing's triad is just ICP across the board. It's not just for hemorrhagic stroke. It's applicable for trauma.
Can a hemorrhagic stroke be caused by a traumatic injury, or does it by that, or is it just like
Then
categorically is only a stroke if it's non-traumatic at origin?
Yes. Because if you got knocked in the head hard enough to cause a shearing of that artery, then that's just going to be a TBI. Okay? Yes.
Can an ischemic stroke become a hemorrhagic stroke? Just like that blockage cause?
Probably not. I guess anything is possible, but most likely not because the hemorrhagic strokes occur because of the compromisation of the structure. Like it's not as strong.
Yeah.
So typically if the arteries are nice and strong structure, even if there's like a dam, if you will, it'll typically hold under that pressure. Are we good?
Mm-hmm.
Okay. All right. So I am going to skip around a little bit. Because for some reason we talk about stroke and then the way to assess for stroke is way at the bottom. All right. So again, guys, we're really going on that differential diagnosis, right? Especially when we talked about cardiovascular, if they're having chest pain, we have got several different thought processes in our brain as to what it could be, right? What's the first thing probably we want to rule out? Heart attack. All right, so what am I going to do to confirm or rule out a heart attack?
Look them up.
Get a 12 lead. Of course, I'm asking sample, I'm asking OPQRST, but I need that 12 lead to tell me this is or is not cardiac related. All right, if that 12 lead comes back negative, what's my next thought process it could be? Well, it's gonna cause chest pain.
Respiratory,
It could possibly be respiratory. What else?
heartburn.
Heartburn. Have they been sick for 2 weeks and they've been coughing and their chest only hurts when they cough? So we start going down these tracks to say, okay, I'm ruling this out or I'm confirming this. So if you have a patient who starts to present with these signs and symptoms, that altered mental status, that unsteady gait, maybe that hemiparalysis, all right, a stroke scale is going to be the biggest way we can determine or be highly suspicious that our patient is having a stroke. All right, we're going to do a FAST test. FAST. Another acronym. Yay. All right, what does F stand for? Facial droop. Okay. What am I going to do to assess if my patient has positive facial droop or not? Sometimes, guys, it is very obvious. All right, if you walk on scene and you see a patient who, you know, their eye looks nice and perky over here and their mouth looks nice and taut, and then it's just like looking like a basset hound on the other side, very obvious that we have one-sided facial droop, right? But still, to confirm that, what am I going to do? How am I going to instruct my patient to cooperate with this test to see if they have positive facial droop?
Have them smile.
Ask them to smile. All right, you got to get really into it and give explicit directions. I want to see your big pearly whites. Give me the cheesiest, biggest smile you can give. I want you to be smiling from ear to ear, right? Because if they give just like a little smirk, you might not can really tell what both sides actually look like. Okay, so tell them to give you a really, really, really big smile. If one side of their face complies and smiles, and you start to get, you know, like the normal little wrinkles around your eyes when you smile, your cheek muscles pull up your mouth, all of that stuff, and the other side doesn't do anything, it just kind of stays there or it barely moves, we're going to consider that positive facial droop. Okay. Everybody good with the facial droop part? What's A? Arm drift. All right. How do we do this?
Has to hold their arms out, close up.
All right. So what you're going to do is you're going to come up to your patient, be aware of normal fluctuations, normal arm strength, because if, you know, you go up to a normal person and ask them to do this for 10, 15 seconds, somebody might, like some people might just might not have arm strength, and it might just be kind of wobbly on both sides, right? Especially if it's a little old grandma. She hasn't been really doing her calisthenics, right? So what you want to do you mind if I can touch you? So you'll go up to your patient, go ahead and grab their arms for them, okay? Put them palm up, hold them in front of them and say, I want you to close your eyes, and I want you to hold both of your arms out like you're catching raindrops, or you're catching snowflakes, or whatever. All right, so have them close their eyes, then let go of their arms. Lift up their arms for them. Give them instructions. Close your eyes and keep both of your arms out like you're catching raindrops. Once their eyes are closed, you got to tell them you got to do it for 10 seconds. All right. Remove the support of your arms. And if you have just one arm just fall completely flaccid and the other one stays up, or if you have one significantly weaker than the other, if we have a positive drifting of one side of that arm versus the other, we're going to consider that positive for arm drift. Just make sure you're lifting their arms for them. Close your eyes, hold them here for 10 seconds, remove your arms, and then see if we have a positive or a very obvious one-sided deficit. What's next? Speech. All right, guys, there's a couple things that can happen with this speech. All right, so we can have maybe slurred speech. We can have maybe no speech at all. or we can have inappropriate speech. All right, so how are we going to determine if my patient's speech is affected? We're going to give them a phrase, and we're going to say, repeat after me. Okay, guys, the most common ones you're going to hear are going to be, you can't teach an old dog new tricks. There is one, the one that's in the book is the sky is blue in Cincinnati, but that's because the most universally used stroke scale came from Cincinnati stroke unit at the hospital. But you can't teach an old dog new tricks, and the quick brown fox jumps over the lazy dog. That one's not as common, but why would you hear that one used? The quick brown fox jumps over the lazy dog. So yes, but why? It gives me a full range of assessing my patient's speech because that sentence uses every single letter of the alphabet. Phonetically, how it's pronounced. So that way, if my patient is only tripping up on one, syllable or one pronunciation of that letter, I can catch it. So we might see a couple things happen when you ask them, hey, I need you to repeat after me. If they are having a very hard time, maybe they're saying the right words, but it sounds very slurred or disconnected, or it's taking them about 30 seconds to be looking at you. You say the phrase and it takes them 30 seconds to start even saying it back to you. We're going to consider that positive for speech impairment. What else could happen?
They just talk nonsense.
Oh, they might start like saying inappropriate words,
Like what?
like curse words. And
Maybe.
Stuff that just doesn't make any
So again, guys,
their words don't make sense together.
so going back to the GCS, that inappropriate response for verb or for verbal, right? Maybe not necessarily, oh my gosh, offensive words like cuss words, which it might be thrown in the mix. But if I say, repeat after me, you can't teach an old dog new tricks, and the patient's sitting there saying blue flower pot, purple kitten, rainbows, that's not what I asked you to repeat. All right, so that's going to be called dysphagia, right? If they're having difficulty speaking. Some things, there's two different ways this happens. Depending on the pressure at the certain part of the brain, they can either come back with blue flower pot, purple kitten, rainbows, and they think that their ears are hearing their brain saying or their mouth saying, you can't teach an old dog new tricks. They think that's appropriate verbiage, right? Or you can have the other side of the coin. They're saying this inappropriate response and they're hearing it and they're like, whoa, that's not what I meant to say. Why did I just say that? That one sucks because they realize something's not right. Most of the time when you have patients having strokes, they're going to have that altered mental status. They're not going to be really consciously aware necessarily what's going on. But if you have that patient who says blue flower pot, purple kitten, rainbows, and they're like, and they keep saying it and they're like freaking out because they're like, that's not what I'm trying to say, you can have that response as well. So if we have any variation or deficit with them repeating that back to me, I'm going to consider that positive speech impairment. All right, what's T? Time. Guys, these patients are super time sensitive, just like my heart attack patients, right? Just like my PE patients. These stroke patients, we've got to get them to the hospital ASAP. Okay, so once you get a baseline set of vitals on scene, make sure your ABCs are intact. If you're suspecting a stroke, this is one of the first things you need to do after you get your vital signs to rule out like hypoglycemia, anything like that. Because the second we're like, yep, positive on the stroke scale, we need to be loading up. We need to be getting in the back of the truck This is a lights and sirens transport back to the hospital. And what do you have to remember to do?
Stroke activation.
Call and report and activate a stroke alert. You can be hauling ass to the hospital and get them there in record time, but if you show up and nobody's waiting for you, oh, sorry guys, the CT scanner's full, you didn't call us. Let me get neurology down here. Let me get the lab down here. You're wasting time for that patient. Because if you call in a stroke alert, if you activate a stroke alert, if any elective CT scans are currently going on, they say, nope, I'm sorry, we got to come back to you. We'll put you in the hallway. We have to clear up the CT scan for the stroke coming in. So that is ready, waiting to go. The neurology team is waiting. They're literally standing in like a big horseshoe for you to just roll up and get them on the hospital bed. The lab team's there to draw blood labs. They're ready to go. Do not forget to call a stroke alert. Okay. How many of the FAS does my patient have to be positive for me to activate a stroke alert? 1. If I cannot have any other puzzle piece to tell me why my patient could be acting altered, if their blood sugar checks out, if their pupils check out, I'm not thinking it's drugs involved, right? If all of their other vital signs, there's nothing else that can make me say, oh, this is why my patient's altered. Even if they check off 1 positive in that stroke scale, I'm activating a stroke alert. Yes, ma'am.
So, for the sake of time, if they test positive for the F part, can you just let it go then? Or do you have to do
No, we want to get, because it doesn't take any time hardly to get the rest of that scale. And guys, too, if we have that facial droop or that arm drift, we want to notate what side, right? So I want to relay that, hey, activating a stroke alert. I'm bringing you a 69-year-old female, positive on the stroke scale for right-sided arm drift and right-sided facial droop. Vitals are as follows. ETA 10 minutes.
So is it possible to have a situation where they might have symptoms on opposite sides, or is it mainly only restricted to one side?
It's technically possible, but it's not very
common.
Yeah. Yeah. Guys, sometimes you get a patient who is unconscious, unresponsive, or is non-compliant. Like if they're just sitting there staring into space, they're not compliant, they're not going to talk back to you, they're not following commands, they're not smiling, they won't, put their arms up. Can you do a fast test on them? No. You can't. All right, that's going to be something, if it is very possible that the patient could be totally altered by the point we get there, we cannot perform a fast test. So that's just going to be a judgment call for you guys. When you call and report, you can maybe talk to the dispatch, the paramedic dispatcher, and be like, hey, this is what I got going on. Everything else is normal. I can't perform a stroke test. Maybe call medical direction. How do you advise? See if you need to activate that stroke alert or not. So you guys, if you have the pressure in or the stroke is affecting or in the left side of your brain, you're going to see the right side of the body have that facial droop, have that arm drift. And guys, if you think if we have arm drift, do you think that patient's going to be able to use the lower extremities on that right side of the body?
Not.
Same. Dun, 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 dun. Again, guys, hypoglycemia looks the same as a stroke sometimes. Intoxication, drug use looks the same as a stroke sometimes. Hypoxia looks the same as a stroke sometimes. So make sure you're getting all of your ducks in a row before you misdiagnose your patient and subsequently don't provide the appropriate care. Again, we've looked at these pictures. They're not labeled correctly, but it is what it is. This is technically an epidural hematoma. This is a subdural hematoma. We'll talk more about that when we get to trauma. but this is that traumatic injury that can cause bleeding in the brain, that causes ICP, that can present the same as a stroke. Something else. Oh, there was a quiz question. Some of you guys, it might have been an airway, or maybe it might be for this chapter, and I might be giving you guys a free answer. How do you think we want to transport these patients? What are some problems that we might foresee if a patient is having, especially that facial droop? What might not they be able to control if they can't control their facial muscles? Their airway, especially their tongue, right? So we might see drooling out of the one side that we're having facial drooping with. How might we transport these patients? What's going to be our best bet? If I have a patient with right-sided facial droop and right-sided body weakness, how do I want to transport them?
You mean as far as sitting them on the stretcher?
So once I get them on the stretcher, I want to transport them kind of propped up on their right side, that affected side. Why?
Because you want gravity to help you, keep them from having any additional.
If they can't control the right side of their face, that they can't swallow appropriately, that's fine if I tilt them up on their right side, because where's that drool going to go?
It's going to go down.
Your mouth. I'm not going to worry so much about aspiration. Guys, you do want to have your suction readily available and making sure you're managing that airway if we do have that drooling, because they're not going to be able to control it. We could aspirate. But transport your patients on the affected side of their body so gravity can be our friend. Okay. You guys want to take a little break before we hop into seizures? Yeah? Okay. 10 minutes? All right. Seizures. Right? Global definition or global concept, doesn't matter what type of seizure, what's happening to cause a seizure. Because there's several different types of seizures too. Sorry, guys. All right, because normally how does our brain work? How does it send those messages to and from the body? Electrical activity, right? All of that messaging is sent through electrical activity, through those axons and those neurons and all that fun stuff. Now, if we have just kind of like an overabundance of that electrical activity, of that electrical surgence in the brain, because guys, what is the brain's default coping method if something's not going right in the body or if something's not going right in the brain? It says what? I need to do what? I need to, have you tried turning it off and turning it back on again? All right, that's what the brain does. So if something's not going right in the rest of the body and the rest of the systems, if you guys ever pass out, if you ever have a syncopal episode, all right, that's the brain's equivalent of saying, okay, we need to refresh, we need to restart the computer, okay? Now with these seizures, especially when we get to the generalized seizures, a seizure is a way of the brain saying, okay, something's not going right in here, we need to do a hard reset. Let's turn it back on, let's turn it off and turn it back on so we can get everything back to our chill baseline. Okay, so passing out a syncopal episode is a refresh. A seizure is a hard reboot. But in any capacity, the brain understands that something's not right. We need to take it back down a notch so things can go back to their normal, back to their baseline, hopefully, ideally. Because if you've ever passed out before in your life, what happens about 60 seconds later? You wake back up, right? Especially if you're hyperventilating, you pass out, your respiratory rate goes back down to normal, all of your levels go back to normal and you wake back up. Okay, so that's kind of what's happening with a seizure. We have an overabundance of that electrical activity, and so it doesn't short circuit. The brain does a hard reboot. Okay? So we have generalized and we have partial seizures. Okay. These generalized seizures are going to be what?
Generally,
All right, large areas of the brain. Okay. So this is going to be a bigger portion of the brain that's going to be affected by this electrical surge and will present in different ways than a partial seizure. Okay. These generalized seizures are going to be the ones, typically the ones that you see loss of consciousness, the head to toe convulsions, all right, the shaking, okay, because a large portion of the brain is affected, it's going to be a larger, a heavier reset. All right, so when we go to the partial seizures, what do you think is happening here?
small source of it.
A small portion of the brain is being affected. It's not the larger portion or the entirety of the brain in its entirety being affected by these electrical surges, okay? So usually with these partial seizures, we don't notice a change in consciousness. Okay, I didn't fully understand this. I went out there first, however months I was working as an AEMT, and we walked into a room and the lady was just doing this. She's like, yep, have another seizure. I'm like, what? No, you're not. You're talking to me. You're faking it, right? No, guys, that happens with a partial seizure. Typically, we will see an isolated motor response, maybe an arm, maybe a tick in the face, maybe a leg, but usually the patient stays conscious. They're very aware of what's going on. It's going to be that focused area to that part of the body. Okay. So you'll notice here, this girl's having a partial seizure. Somebody, dad, significant other, I don't know, is giving her kind of like rubbing her shoulders, trying to make her feel better, I guess. But you'll notice that she's got a tick in her eye and in her face, and that's where the seizure is focused on. Notice here. So she's talking as it's happening. And this next lady kind of talks you through. I think she's got a history of seizures. She's got like her own YouTube channel. She kind of tells you.
This focal motor seizure involves just my left arm this time. As you can see during the video, it's clenched pretty tightly and it's getting to be a little more on the painful side, but not too bad just yet. It was happening during one of the big seizure spells that I had, little clusters or whatever you call them. And it hadn't moved down to my leg on this one. So it's not an easy one to watch, but it's not very difficult either.
All right, so it's just isolated to the arm. She didn't fully go out of it. She's aware of what was happening. So if you want to compare, like a generalized seizure is going to be a head to toe assessment. Partial seizure is going to be a focused assessment, if you will. Right?
Professor A.
Yeah.
This might be kind of like a reach, but how can you differentiate between a seizure and a possible Tourette syndrome?
So that's going to be interviewing your patient, getting that medical history. Typically, if you have these focal seizures or these partial seizures, There's not really like the verbal outbursts like there could possibly be with Tourette's. But yeah, it's just going to be more interviewing your patient.
Okay.
So with partial seizure, I guess it presents as a generalized seizure, but they're still conscious throughout. What with that?
So the partial seizure, the generalized seizure is going to be the head to toe. They're completely unconscious, unresponsive. Their entire body is convulsing. With this, yes, you might see some convulsions, but it's going to be isolated to one area, and they're going to be lucid.
So if they can you have like a generalized seizure but still be lucid throughout?
No.
Is that seeing that happen?
That might be like their entire body was convulsing, and they were talking to you while it was going on.
Well, I mean, they couldn't really like control their mouth, but they like could see them like making eye contact.
Purposeful eye contact? I would have to know more about that, because typically if it's a generalized seizure like a grand mal tonic-clonic, there's no cognitive brain activity happening because it's doing that hard reset. There's no consciousness about a tonic-clonic seizure. So yeah, I would have to know a little bit more. So again, guys, you can have a complex partial seizure. What that first girl was having, the twitch of the eyes and the lips, or you can have the focal motor seizure where the lady's extremity was isolated. All right, what is an aura? Some people, not everyone who has seizure disorders, but some people will have an aura or receive an aura before they have a seizure.
It's a visual thing that occurs before seizure.
So could be a visual thing. Could be what else? It's some type of sensory, whether it's a certain smell, whether it's a certain sight, something that they might hear, that if they're smelling burnt toast and they are nowhere near a toaster, they're nowhere near anything that can smell like burnt toast, and nobody else in the room smells burnt toast. They're like, okay, I'm smelling this burnt toast. That means in the next couple of minutes, I'm going to have a seizure. Or they could see, they could start to have visual disturbances. They could hear maybe something that nobody else in the room hears. And that is their aura, that they know, hey, if I hear, see, smell, or feel this sensation, that's my trigger warning to say I'm about to have a seizure. It's not everyone who has a seizure disorder has this. All right. So if we have a patient who maybe it's an unrelated call, right? But we established that they have a seizure history. What do we want to ask them? Do you have an aura? If so, what is it? And hey, can you let me know if you're experiencing that aura so I can prep for you to have a seizure soon? Right? Just a good bit of information to know. But yeah, if they have an aura, it's a very reliable, hey, tell me if you smell burnt toast type of thing so I can prep for the seizure that's impending.
Instructor A.
Yes.
Can auras also occur with people who have chronic migraines?
Yes. So, yeah, in a sense, because like with me, like I said, I'll start to lose my peripheral vision before the actual migraine pain starts. So if I start to lose my peripheral vision, I need to check my sugar or prep for a migraine. So sometimes you can get especially the visual auras for migraines.
Okay.
Why do they think some people have them and some people don't?
I don't know. But this is also how they train and utilize service animals, especially service dogs, for people who have epilepsy or seizure disorders. They're trained to pick up on a certain hormone that's released before the patient has a seizure. The dog senses it and then will go and alert the owner if they don't have auras. Like they'll go scratch at the owner or give some type of signal to tell that person, hey, I'm picking up on this, you're about to have a seizure. So if they're, holding a pot of hot water or a baby or something like that, they can, you know, have time to set that stuff down and sit down so they don't have trauma secondary to the seizure. It's really cool. All right. So this generalized seizure, like we were talking about, guys, this is going to be, you're not going to have any response from your patient. We're going to have that head to toe convulsion. A greater area of that brain is having that electrical surge. The brain says, hey, this is a hard reboot. We got to get this under control so we can kind of, you know, start back up at our normal baseline. Guys, during these seizures, you're going to see what we call a tonic-clonic response. All right, so again, from head to toe, you're going to have uncontrolled muscle spasms. All right, so when we see the tonic aspect of a seizure, what is this? Right? Does anybody have seizures or know anyone that has seizures? Yeah. So we can kind of, before the convulsion starts, we see the tonic aspect where everything starts to tense up. So you might see like an arm start to kind of raise. Sometimes patients that are in this tonic portion of the seizures will kind of have like a verbal cry out, just uncontrolled. And then the clonic is where we actually start to see like the uncontrolled spastic convulsions.
So,
This
question
tonic
then.
part is seconds before the clonic part. So it's not like the tonic happens and then 5 minutes later the clonic comes along. It's just in very quick succession.
So that falls within the same area of like grand mal seizure or something?
So tonic-clonic, grand mal seizure, it's the same thing.
Oh, okay,
Yeah,
okay.
they're interchangeable. They're both generalized seizures. They're both going to have the kind of the freezing up, the tensing up, and then the convulsion from head to toe. Guys, I can't stress enough, when you're having an active generalized seizure, it is extremely taxing on your body. It is like running a marathon while on crack. Okay? Your heart rate substantially goes up, your blood pressure goes up, your respiratory rate goes up, but it's not really effective. All right? So it's very taxing on your body, the physical act of having an active generalized seizure. So that's going to lead into some things that we should expect after the patient's done having a seizure. All right, we'll get to that in a minute. But
there's like some hypoperfusion to the brain.
Absolutely. Absolutely. These seizures should not last. Guys, this is a long duration for a generalized seizure. 5 minutes, that's an extremely long time to be seizing. That's not going to be good for your body. Typically, they last 1 to 3 minutes. Usually on the lower end, usually around a 60-second mark. Okay, but if we have been actively seizing, like witness seizing for over 5 minutes, we're not in very good territory. Okay. Intense salivation. We'll talk about that, guys. You're sweating from head to toe. That's all going to play into how we should treat our patient after. What's a postictal state? Postictal. So that is after the physical motion of that seizure. You're not convulsing anymore, but you don't go right back to normal. All right, we're doing a hard reset, hard reboot. When we have the seizure, it takes a little bit to power back up that computer to have it on your home screen and have all of your programs functioning at normal speed, right?
So this girl on the plane, she was prone to seizures and she happened to have no why with this. She turned gray at the end of her seizure and just stayed like that. Why?
Because you become hypoxic during a seizure. All right, so this postictal state, this is where the actual physical motion of the seizure is done, They're not going to be convulsing anymore, but it's going to take a little bit for them to wake up, to become ANO times 4, to become responsive, to get back to that normal functioning state. Guys, that postictal state can last up to 30 minutes. So the second your patient stops seizing, do not expect them to pop back up and be like, well, that was a doozy, I'm good to go. Right?
So basically, that's where we just need to make sure we do regular vital checks on them, or do we not touch them in that postictal?
Absolutely. So up to 30 minutes, guys. If we significantly past that 30-minute mark, and my patient's still postictal and they're not really waking up, we might have a problem, right? But you can expect up to 30 minutes for them to wake back up, get their bearings, and be totally back to normal. Right? That's in your postictal state. All right, so we'll watch these videos and then we'll talk about management of these patients. All right, so this is videoed by his mom, but this is an example of a tonic-clonic seizure. So this goes on for quite a while. Once he stops, I want you to notice how the color in his face starts to change. So he's getting a little pale now. See how he's starting a little blue? So his lips are cyanotic right now. So he's got that blue purplish tint to it. He's kind of got a blue pale color to his face. We've got the drool coming out. He's postictal right now. Okay. So this guy's in the hospital. You'll see this a lot. If people just randomly start having seizures, guys, that's not normal. There's something happening in the brain to cause you to have these seizures. So probably what's going on with this guy is he's been up to this age in his adulthood. He's never had a seizure before. He had a seizure. They've got him in the hospital and they're doing a seizure study. Okay. They have all of these electrodes connected to his head so they can monitor brain activity. They're trying to figure out what's triggering his seizures so they can treat them proactively, right? Notice he's got all of these pads on the rail, the bed rails, so he does not cause trauma, like if he hits his head on it. But that's what all these stickers are for and why he's in the hospital. They're trying to figure out why he seized. So he's coloring. Notice he kind of just like, he stops and kind of stares off. Kind of out of it right now. His tonic. Kind of calls out. Now he's in the clonic. They're getting their suction out, trying to protect that airway. Okay. I'm not on board with this. I'm going to let that minute. see,
He
the
does,
quality's
okay.
not as good, but he's already kind of pale, blue on his lips. Now he's post-sickle. All right, guys, these are intense. Okay, they're not easy to watch, especially if you've got like a loved one who goes through this, or if you're having a patient that goes through this. Maybe you understand why back in the day, before we knew a lot about science, a lot of people would think that people who had seizures were like possessed by the devil or like demons. Because I mean, the way the guy, screams out and starts to convulse and stuff, that was a big thing back then. They didn't understand, but it's intense to watch. What did you notice about both of their bodies and especially their breathing when they were seizing? Why did they become blue at the end of seizure?
They're not able to properly inhale during that
So
time.
you heard them, especially that first one, right? You could hear the air moving, but guys, every muscle is tensed up. Everything is just clenched down. You're not effectively getting any chest rise when you're actively seizing. You're not effectively breathing. You're trying to move that air, but it's just moving in and out of the mouth. It's not really getting down into the lungs. So that first guy only seized for maybe 40 seconds, maybe 60 seconds, and you saw how blue his mouth was at the end. Okay, so you absolutely, in theory, need to do what for a patient who's actively seizing? In theory, we should be bagging them, right? Guys, is that at all possible? No, it's not. All right, they're going to be convulsing all over the place. And a lot of the times when these patients seize, their jaw clenches shut. All right, the muscles in their face and their jaw just tightens down and it won't move. So if you've got that extra salivation and you've got a clenched jaw, that's why a lot of times if you hear they're foaming at the mouth, that's the rapid movement of all of that extra saliva moving back and forth between the teeth and stuff and creating those bubbles. That's why they foam at the mouth when they seize.
So should he really try to suction while they're seizing?
You're not really going to effectively be able to manage the patient's ABCs until they're post-ictal. What can you do? What's the best thing you can do for your patient?
Make sure that the area where they're convulsing is clear.
Make sure they don't concentrate to themselves. Maybe, guys, do not try to hold these patients down, okay? Because that can cause further trauma. We're not going to try to suppress their movement. It's just not going to happen. Best thing we can do is maybe put, a pillow or try to protect their head from hitting up against anything. Try to protect from further trauma, but don't hold them down. All right, what can we do? It's probably not going to do much, but it's better than nothing while they're actively seizing. What was she trying to put on that patient? A nasal cannula. So maybe she was trying to blow by. Maybe that was the only device she had in the room. You're not going to get a nasal cannula on a patient who's actively seizing. To get each nostril in there and to loop it around while they're moving, not going to happen. So what can you do? Maybe blow by. What's a lot easier? You're not going to be able to access that. Or try to put a non-rebreather on when they're actively seizing, or try blow by. Try something, but don't expect to be able to bag or really even suction a patient who's having an active seizure. Okay, that's going to come into play during that post-ictal state. The second that patient stops convulsing, what do we need to do? Okay, so yes, get them on oxygen, but first, suction if needed. All right, all of that extra spit that accumulates, they're not going to be able to protect their airway if they're in that post-ictal state.
Yeah.
Suction. Possibly think about having these patients placed in the what position? Recovery position. And then we can take a step back and see, okay, do I need to bag my patient? Do they need a non-rebreather? I probably wouldn't, I don't want to say I wouldn't bother you can attempt to place an adjunct, but it's only a matter of time before they become more conscious and have a gag reflex. So then we run the risk of, if we have an OPA in place and their gag reflex comes back and they puke and they still can't protect their airway, it's just going to be a judgment call on you guys. MPA on its own, right? But make sure that postictal state, we're really hopping on their ABCs because they've been hypoxic the entire time they've been seizing. They've got to get that oxygen on board. Okay.
So, question, Professor A. Once they get in that postictal state, and we're talking about the managing the airway portion. I mean, I know you were saying that you may want to try to do the rebreather, but would you be better off going ahead and getting them on some regular oxygen versus the rebreather, or would it be best to do the rebreather?
Like through a BVM? Is that what you're saying?
Yeah. Like, I mean, are you talking about like the free flow oxygen using the rebreather, or actually doing the BVM?
So it depends on what their respiratory status is when they're postictal. What do we anticipate their respiratory status to be?
It's not going to be very high, I know that much.
So it actually is, their respiratory rate's going to be significantly increased. Just like their heart rate's going to be increased, just like their blood pressure is going to be increased. Okay, so they're going to try to compensate with that rapid respiratory rate because they haven't been breathing effectively the whole time they've been seizing. So it just depends. If they've got very shallow chest rise, then yeah, I'm going to bag them, right? If they've got snoring respirations, or if for some reason their respiratory rate is low, then yes, I'm going to bag them. But typically they're going to be tachypnic, and usually a non-rebreather at 15 liters per minute is going to be sufficient. But if their chest rise is shallow or anything like that, then yeah, I'm going to use a BVM.
Is there any complications with that form of retention?
It's just going to be awkward. Suction and oxygen in that postictal phase. All right, because guys, what else might they have had transpire during that seizure, especially if they clenched their jaw down? Sometimes they can chip a tooth if they're biting down or convulsing that hard. Sometimes they can bite their tongue and create an airway obstruction in the form of blood. So you've got to get on top of that airway the second they go postictal, because that's our biggest concern for these seizure patients. All right, anticipate a high heart rate, high blood pressure, usually a high respiratory rate, but that airway is going to be our number one concern. Okay. And guys, just be aware that if somebody who has never seen somebody have a seizure before, it's a very traumatizing experience. And they might tell you, yeah, they were seizing for 10 minutes because it might have felt like an eternity for watching that person seize. If we can, try to get the most reliable source that we can to see how long they were actually physically seizing, because that's going to be something that we need to pass on through that report. Okay. Also, what should we expect during a seizure and in the postictal phase? It's not pleasant. Incontinence. Right? Because what is your urethra and your rectal sphincter? Muscles. Guys, you lose control of every single muscle in your body, and you have uncontrolled convulsions of those muscles. So more than not, you will have urinary or fecal incontinence during a seizure, possibly, obviously, leading into that postictal stage. Okay. There are several patients out there who try to fake seizures, and I give them ample credit if they commit to the role and they pee themselves, because that has happened before. All right.
Why would they do that?
Huh?
Why?
I don't know. I don't know. Because if you're convulsing like this, you're not talking to me while it's happening. Okay, if you're convulsing like that and having a generalized seizure, you're not going to hold your hand out when I mention to my partner I need to check a blood sugar. So there are patients who will try to fake seizures. They're just, now that you know what happens during a generalized seizure, you maybe can be like, oh, that's odd. That doesn't normally happen. But usually you will see urinary or fecal incontinence because of the musculature component. All right, absent seizures. These are also called petite mal. So again, those tonic, clonic are also referred to as a grand mal seizure. These are really tricky to diagnose. Typically, these are diagnosed and are very prevalent in pediatric patients. This is one of the things that usually they grow out of, just like the pediatrics can grow out of asthma, heart murmurs, all of that stuff. They can just grow out of it as their body grows and matures. This is one of those things. I had one student who had a friend who was, an adult and still had absent seizures, but it's very uncommon in adult patients. What's happening here is you will be, just like bebopping along, you'll be walking down the sidewalk, and then all of a sudden you'll just like zone out. All right, you might still physically be moving, you're not really talking, but you just kind of like tunnel vision. Has anybody ever seen the movie Rango? Like the lizard with Johnny Depp in it? The girl lizard, like she like freezes and like stops talking whenever she gets scared or whatever. That's kind of what this is. So we'll watch this video. The mom, if you have a child and you're suspecting that they're having these absent seizures, the neurologist is going to tell you record them 24/7. And we'll go through that recording and see if we can pick up like the moments that they're having these absent seizures. So I think this is Aubrey, is that her name? She's dancing with her cousin. You'll notice they're dancing and all of a sudden, oh no. Hold on. There's another video I used. I like this one better, but I guess we'll watch the other one.
Long video, honey. I can see you. That's Julian. She's still physically moving, but she's kind of zoned out, and then now she's out of it. Haley, what are you doing? What's your favorite thing to draw? Like parties? Like people at parties or just like flat parties? Wow! Haley? Haley? And so guys, why do you think all those waves, William, are making water go out of the pool though? Why do you think those are hard to diagnose?
seizures so fast?
So they're fast. If you don't have kids, you might not understand. Kids do that anyway. They will zone out. Like my son will be in the backyard and he'll just be like, following a bee or something. I'll be like, Walker, Walker. Like I have to yell his name 5 times. He's like, oh, hey, yeah, you talking to me? Like kids zone out just normally, right? So, yeah. So you could see she was still physically moving, but she was just like focused. I think in the comments on that one too, another indication she was in that absent seizure is she would have like a hard swallow every time she went into kind of that trance. So not a whole lot we can do about these. It's not a super big concern because her body systems are still functioning effectively when she's in that absent seizure, right? You typically only see these in pediatric patients, but there's not a whole lot we can do, and it's not a huge concern because she's still perfusing, right?
Instructor A.
Yes.
So with an absent seizure, what exactly is happening with like the electrical activity that causes it?
There's some type of like electrical storm, but it's very subtle and it's, just very easily reset, I guess.
Okay.
It kind of puts you in the mind almost like a mini power surge almost in the brain.
Yeah, possibly. I mean, that would be a good analogy. All right, status epilepticus. This is going to be if a seizure lasts more than 5 minutes. So again, guys, seeing how that, especially that first video we watched of that guy, how cyanotic he got, how taxing it was on his body just after like a 45-second seizure. If we're actively seizing for more than 5 minutes, our body is not going to be perfusing at all, right? So this is bad territory. Or if you're consistently seizing, going into postictal state, not coming out of that postictal state and going back into a seizure, that's also considered status epilepticus. Okay. So this is something we need to keep in mind, tracking the time of the actual seizure and making sure we're coming out of that postictal state. Also keeping track of the time of the postictal state.
So the going in and out, would that only be after 5 minutes, or is it happen at home?
If you are consistently, even if you seize for 60 seconds, you go postictal, you don't come out of that postictal state and you go into another seizure. And that process repeats, that's also considered status epilepticus. It's not good for giving your body enough time to reset and refresh and perfuse again.
So to extend off of that, Professor A, just from the EMT standpoint, let's just say we get on the call and we do have a situation where they're going through that epileptic state or whatever. When they get into that point of that postictal state, it's going to be kind of dark to say, but if we do run into a situation where they do have that going on, then the best bet in an effort to make sure that they're getting proper airflow, we need to do a rebreather. How do we deal with that when it comes to making sure we can control that?
When they're in that postictal state, you're going to manage appropriate to what the patient's presenting with. If they're having appropriate chest rise and fall, then I'm probably going to put a non-rebreather on them. If they're having shallow chest rise, then I'm going to bag them.
Okay, and because that's why I was wondering, because if it's a situation where they could potentially go back into that state, we basically get clear if they start again. Is basically what I'm trying to understand. How do we?
The best you could do is leave the non-rebreather on the patient while they're actively seizing, but you're not going to be able to do physically anything else with the patient if they're actively seizing.
Got it. Okay.
Yeah, and guys, if you got a patient who's doing this, make sure you got ALS in route because I have drugs that I can give to stop tonic-clonic seizures. Okay.
Could all of that lead them to develop shock?
Yeah, absolutely. There's several different reasons that seizures happen. Okay, we can have a seizure if your blood sugar is too low. You can have a seizure if your blood sugar is too high. You can have a seizure if your oxygen levels are too low or too high, your electrolyte levels are too low or too high. It could be a structural issue, like you could have a tumor, any type of ICP. Guys, if you have a hemorrhagic stroke that causes immense ICP, your patient can seize. If you have a TBI that causes immense ICP, your patient can seize. All right. Poisoning, drugs, withdrawals is a big one. And febrile fevers or febrile seizures. What happens here? We talked about this yet? So you'll typically see febrile seizures in who? Pediatric patients, typically the infant and toddler range. All right, what's happening? So yes and no. A big misconception is that they seize because their temperature gets at a higher level. Yes, that can happen. All right, I have seen that happen. I think I told you guys it was AFD who was training, doing like live burn training in the middle of August. In the summer, full turnout here. There was like 6 or 7 of them who came into the hospital with heat exhaustion and heat stroke. And one dude, his temperature was literally like 107.2. He was intubated, he was seizing because his temperature was so high. But typically, with the pediatric patients, the infant patients, it's not always so much as to how high the fever gets, but how quickly it gets that high. If you start out at a 100.1 temperature and you get up to 100.5 over the course of 4 hours, 6 hours, that's fine. Your body can acclimate, your body can adjust, right? But if you go from 100 to 105 in like an hour, your body doesn't have time to compensate, it doesn't have time to adjust. That's when your brain's like, nope, let's reset, refresh. Okay. So yeah, if we have a pediatric patient who's seizing and they have a fever, probably what's going on, we want to ask how long the fever's been that high. When's the last time the patient's caregiver has given them any medication, if any, to help bring the fever down type thing. Yeah, so. High stress can cause a seizure. I've ran that call. Dude was getting married at the St. Regis. If you guys don't know, St. Regis is like swanky Buckhead hotel. Everybody had flown in from Texas to have the wedding here. This was the morning of the wedding. Apparently, the night before, there's a little too much alcohol at the rehearsal dinner, and the soon-to-be bride came clean and said that she was having an affair with the groom's brother. Keep in mind, we get on scene. This is in literally the penthouse suite of the St. Regis. The mom, the patient's mom, dude's like 30-something, but she meets us at the door and she's like spilling all the tea. She's like so excited. She's gossiping about what happened. And she's like, but you know what? It's probably for the best because we didn't really like her anyway. And I'm thinking, well, she's with your other son now. So she's still like, so probably accumulation of things because dude, the groom, the to-be groom, consumed a lot of alcohol. And high stress, all of that stuff can cause seizures. Alcohol is a diuretic, which makes you pee a lot because technically what is alcohol to our body? It's a poison. But yeah, so there might have been like some electrolyte issues because he was dehydrated and all the stress. But yeah, dude had a seizure and we got there, he was postictal. There was a big pool, not big, like a pool of blood in the carpet that was like snow white carpet. And I just was thinking, dude, they're gonna charge you so much money to clean that. But yeah, guys, what's something we need to keep in mind, because you see here too, epileptic, like a congenital thing, like you're born with this hardwired in your DNA to have seizures, okay? What if we come on scene and a patient had a witness seizure? They're postictal. By the time we get there and we treat them, they come around, they're ANO ×4, and they don't want to go to the hospital. Can we take them? No. right? But there's a couple things we want to consider. If I come on scene and somebody had a seizure and somebody called, we get there, they're postictal, they wake up, they're ANO times 4, and I can establish that this patient has a history of seizures, am I that concerned about not transporting the patient? No, because this is somewhat normal for them, right? I can make sure, hey, have you been taking your meds like you're supposed to? Have you had any dosage changes lately? Are you drinking any alcohol or doing any drugs with your medication? Because that can affect the way they work. But if they say, yeah, I have a history of epilepsy, I have one like every week, this is normal for me, am I going to be okay? I'm still going to, go through all the steps of a refusal, but am I going to be okay leaving that patient, by themselves? Usually, yeah, if I can establish that it's normal for the patient. Now, this dude at the St. Regis never had a seizure before in his life. Okay, we get there, he's postictal, he wakes up, he's adamantly refusing to go to the hospital. Am I going to push a lot harder for that patient to be transported than somebody who normally has seizures? Yes. Guys, there is something going on to make your body have a seizure. Normal, healthy people don't have seizures. If you've never had a seizure in your life, you absolutely need to go to the hospital and get blood work done and get a CT done to make sure we're figuring out why you had a seizure. Okay, so you need to push really hard if these patients wake up, they've never had a seizure before, they might be embarrassed or, worried about cost or something like that. You really, really, really want to urge them to go to the hospital. And if they still refuse, that's an AMA. You're going to call medical direction. You're going to do all of that stuff. Because who's to say once you leave and they drive away, they don't have another seizure, they get in a wreck and they kill somebody. That's on you. Okay? Just some medications that can control seizures. If your patient tells you they take peanut butter balls to control their seizures, they're talking about phenobarbital. They just, peanut butter balls, phenobarbital. I don't know. Depakote, Dilantin, Keppra. That's actually one of my allergies. They try to treat my migraines with Keppra and not good. I tried that one too. Klonopin, that's a common one.
Topamax makes you forget everything.
Topamax made my face go numb. They're like, oh, it's not really helping, let's up the dose. And they like double the dose. And I'm like, no.
Topamax reacts with like 2 of my other meds. My mom's on Topamax and Keppra for her stuff.
Have you ever tried the monthly shots?
Imitrex? The monthly shots?
There's like a new
Botox? They say Botox can help with migraines.
They just came out with a new like auto-injector. Really expensive.
It's weird, but my pregnancies kind of cured my migraines. Knock on wood. Like I have them like maybe a couple a year instead of a couple a month.
I used to get them a lot when I was out of shape. After I got in shape,
Yeah, diet change helps a lot. All right, we talked about that. We talked about this. Fainting. Again, guys, syncopal episodes is a way for your brain to refresh everything, okay? So if your patient has a syncopal episode, let's do a 12 lead. Let's make sure that the heart wasn't acting funny to make them pass out. Get all your vital signs, make all your questionings. Don't miss any questions. See if we can figure out why they had a syncopal episode, but it's also another way that the brain can kind of restart. All right, talked about all of this. Questions, comments, concerns?
Can you have seizures with ischemic strokes, or is it usually
It's technically yes, it's possible, because if you're in a state of hypoxia, you can have a seizure because you're hypoxic, but you usually see the seizures more so with hemorrhagic because of the ICP, because of the pressure. Okay, am I good? Ish.